Executive Director of the Vermont Medical Society, representing physicians and PAs. And this is actually my first time testifying here this session, so thank you for having me. So just a reminder that we represent individual clinicians. We don't represent their employers, the hospitals, the FQHCs, the private practices. They are located in all of those settings, but we don't speak on behalf of the entities. We're here talking about what we hear from our individual clinicians who are our members. And they are both primary care and specialists. And I will say from what we hear from our members is that Vermont's regulatory structure for healthcare is very confusing. There are a lot of, it's really at least 4 locuses of interest and control, and not that that's necessarily a bad thing, but again, it is hard to navigate as an individual clinician. So Green Mountain Care Board, the legislature, Agency of Human Services, Department of Financial Regulation. And I think, you heard just earlier this morning about a collective action problem. And I think sometimes that can happen with a lot of regulators involved in the same issues, because then it becomes, either hard to know, certainly from an individual clinician's perspective, where do I go with this problem? So we know the problem. You hear them from your members. We hear from your constituents. We hear them. There's a great summary for those who couldn't listen to the last Green Mountain Care Board meeting with the initial feedback from the Oliver Wyman groups that they held all across the state. So what are, paperwork burdens, prior authorization, administrative burdens, workforce, recruiting primary care and specialists and nursing and all levels of workforce. Those are some of the big issues that we hear from our members, and that the primary care advisory group to the Green Mountain Care Board shares with the Green Mountain Care Board. But then, it's hard to, where does that live? So prior authorization, for example, Green Mountain Care Board certainly hears about it from the members and has had forums on it, but often we've heard, they're not really the regulatory home for that. Department of Financial Regulation has a piece. They have excellent data around sort of the current state of prior authorization, but they just testified upstairs on another bill saying, well, we're not necessarily the ones to kind of move the needle on that or force, reduction in prior authorization. Legislature often cares, but sometimes has limited sort of ability to dig into some of these issues in limited time. So that's, so the frustration we hear from our members is we've been, they've been talking about this for decades, and yet we haven't really been able to move the needle. So that's just sort of our big picture, and then we add sort of then the blueprint on primary care lives elsewhere. So that's, I guess, my big picture statement is we do support the overall look at who regulates healthcare in Vermont, and can we make it more streamlined or more clear kind of what the realms of jurisdiction are. So we do support that kind of look at how we're doing this work in the state. But then with those kind of preliminary comments, I do have comments on a number of the specific sections. If you would indulge me, I want to at least pull out, my testimony goes through a number of them. I do want to highlight a couple of them in particular. 3 sections, section 3, 5, and 6, both add language around equitable reimbursement. We have a lot of questions about what that means. There's no definition of that, and actually we've heard kind of even some conflicting concepts in people's heads from testimony of what that means. Does that mean equitable between types of providers, entirely different types, like between hospitals, independent practice, designated agencies, home health, or does that mean within a provider type, like all hospitals? So it just, to us, without more of a definition and criteria, it's really hard to assess the impact of that addition on different provider types. And we think actually there's confusion in the bill, because the bill in other language uses a lot of different types of descriptions of the goals for payment around, like sustainable payment. We actually really like some of the existing underlying language. For example, in section 5, it says that the intent of the General Assembly to ensure payments to healthcare professionals are consistent with efficiency, economy, and quality of care, and will permit them to provide on a solvent basis effective and efficient healthcare services that are in the public interest. I love that language. I'm sure that took a lot of smart minds putting that together. I'm not personally, my view is I'm not sure we need to sort of add more terms into that. I think that's a great aspirational statement of what we want in reimbursement. We had some concerns with moving on to section 4, with moving some of the tasks for Green Mountain Care Board to AHS, not so much that we don't think they could live well at AHS, but we want to make sure wherever they live, so things like reviewing existing requirements for healthcare professionals and professional satisfaction. We want to make sure that that has enough attention and resources wherever that lives. So again, less of a position on it should be here or there, but that whatever entity is in charge has a focus on provider satisfaction, administrative burden, things like that. So sort of similarly with Section 5 about the workforce strategic plan, we don't oppose that move. We think that actually already really lives in AHS. But again, we also think Green Mountain Care Board should still be aware of workforce issues. So just making sure where things are moved, there is resources and clarity. I actually didn't, I accidentally left this off of my testimony in Section 6. We have some concerns with adding language around reference-based pricing. Given where it is, I looked back at the section this morning and realized that would apply to all provider types. There could potentially apply to all provider types where that language is added in, and we're just not sure how that, again, would, how and whether that really does apply to all providers. Section 9 tasks the Green Mountain Care Board, or requires the Green Mountain Care Board to have a mediation process prior to any non-renewal of an insurance contract. We have a concern about unintended consequences, especially for small and independent provider types. That I don't know if that was what the scale was envisioned, but small providers or any provider may drop insurance contracts for many types of reasons, from excessive prior authorization denial rates, slow payments, to administrative things like our practice is closing, or I no longer offer OB services, or things like that, and so I no longer need to participate with this insurer. So requiring all instances to go through mediation, we think would add significant administrative burden and cost to the healthcare system and to smaller practices. And we're also unclear the capacity for Green Mountain Care Board to mediate all such cases, and are there criteria? What does that process look like? We strongly do support Section 10, aligning credentialing and quality measures from Medicare to other payers. Credentialing, this committee has heard a lot about licensing barriers at various times, and sometimes the delays to getting a new provider on board or moving into the state when there are licensing delays. Well, the other big delay is often credentialing. That's the process of getting approved by an insurance company to be able to participate with that plan and bill patients with those plans for your services. That can also really delay getting somebody on board even once you're licensed. And so we strongly support any efforts to streamline and simplify credentialing. We adopted a policy statement about the burdens and urging more streamlining of credentialing in 2018. Similarly, with quality measures, Vermont has done a lot of work in this area over the years, trying to look at how can we get on the same page with what we're asking providers to be measuring. Can there be consistency between the blueprint, the ACO, the insurers? And Vermont has made actually quite a lot of strides in that direction, but anything we can continue to do to have one set of quality measures we can all agree on, rather than for each payer having to gather different data, that would make a big difference. So sections 11 and 12 add a line around measuring and basing decisions on provider productivity. Section 11 adds that to the hospital budget review process. Again, with the lens we have of the individual provider, first of all, we're unclear the intent of that language, and sort of is more or less productivity good? What metrics would be used to determine it? What's the goal of that? In addition, the ongoing push for just greater productivity for its own sake and shorter appointment times is one of the leading factors to primary care burnout and dissatisfaction with providing patient care. I'm sure you know from the patient experience, being pushed in and out of the door is often not very satisfying. And also basing sort of the success of our healthcare system on productivity, however that's defined, can actually run counter to the goals we think of payment reform and global budgets, which the whole goal of which is to allow more flexibility, more autonomy. However you need to take care of this patient, maybe it's a 1-hour appointment, maybe it's a 2-minute phone call. Your payments and your measurements of success shouldn't be based on how much time you're spending. It should be, are you able to deliver what that patient needs? So we have concerns with adding that phrase in those two sections. We have some questions in section 12. There's adding consideration of spending across sectors in the healthcare industry to the Green Mountain Care Board role. We have questions about where the Green Mountain Care Board would obtain this data, especially from entities they don't currently regulate. So independent practices, FQHCs, others. And would this impact the administrative burden on small entities to provide that data? Is it bringing them under Green Mountain Care Board regulatory purview? And really what impact that would ultimately have on regulatory decisions. So would want more information about the impacts of that change. Skipping to section 17, we have concerns with all mergers, affiliations, or divestments needing to be reviewed and approved by the Attorney General's office or Green Mountain Care Board. Currently, this has no monetary or entity size limits on it. And small practices may affiliate or merge at any time, especially when in precarious financial situations. Or just over the past couple of years, been several small primary care practices that have moved from hospital-based to joining other independent or FQHC-based practices that's allowed them to survive and stay open to patients. We're concerned that the expense and regulatory burden of needing to go through a review of any of those types of transactions would mean those small practices may just close. You know, they may not be able to hire attorneys or others to help them go through a whole review process. Section 18 is the data piece. We really just have questions about this piece, sort of the intent of it and the implications, though ultimately we're supportive of providers having both clinical and claims data in an integrated way, so that you not only know sort of how your patients are doing clinically, but what the costs are and are there lower cost options, that kind of thing. So that's an important goal. Not sure about the actual specific language. One of the pieces I definitely wanted to bring up, because I haven't heard many other witnesses mention it. In your walkthrough of 151, you discussed integrating some components from of S211, you discussed adding some pieces from S151, which is on your wall, to the bill. Whichever way you go, I just want to express strong support, and I would be happy to come back and talk about any of these sections in more detail, but we are very supportive of a number of the pieces of S151. I do want to just flag a couple. So I know you mentioned that you already last session asked for a study of Blueprint payments of a patient-centered medical home payment. That's the payment to practices to help them sort of maintain certification as a Blueprint practice. That report, I don't know if it's been submitted to you yet, but it is done and it is coming to you.
We have it. I think it's
have it.
I think it's posted. I'm not sure. I know I've read it.
So you may not need that exact language asking for a report, but there are some implementation recommendations in that report, which we strongly support. So we would ask you to look at that and consider including mechanisms to have all payers contribute equally to that program. We strongly support looking at Medicaid rates and making sure they're an adequate percent of Medicare rates. There's a section in that bill which I think does integrate very closely with the AHEAD model, looking at the percent of spending healthcare dollars that go to primary care. We would really encourage the committee to look at that and support that. There's the workers' compensation piece. There's some prior authorization pieces. They are working on that upstairs, but I think, however that integrates with this work, we strongly support. So, and there's some other prevention pieces around STIs and colorectal cancer screening. So I won't go into detail on any of them. We're happy to come back in any more detail, but thank you for considering that. We would definitely encourage moving those pieces forward that really strengthen primary care and prevention services.
Thank you. Questions?
Thank you.
No, this is really helpful.
Sure.
Thanks
for
so
having
much.
me.
And we probably will ask you at some point to elaborate a little bit on 151.
Great.
Sarah, welcome back.
Thank you. Sarah Teachout with Blue Cross and Blue Shield of Illinois. The quick Netflix recap of my testimony last week. The Green Mountain Care Board needs to remain independent and have full oversight over both healthcare policy and regulation. We believe that AHS as a government payer through the Medicaid program has an inherent conflict with commercial payers and therefore should not be given authority over decisions like global hospital budgets that put these interests in direct conflict. And then the last thing is, as I go through the sections, I'm definitely going to point out pieces in this bill that we do support, but we feel that overall, the harm does not outweigh the good in the switch between the regulatory oversight. So I was going to jump into section 2, no surprise.
We don't have your testimony, even unless, I don't see it on.
Sorry, I was changing it, because you gave me more time.
I did. Okay, well, that's great. If we could just get it when you're finished, then we know what's coming up.
Sure.
Okay.
Yep. So section 2 of the bill mandates that DFR require health insurer participation in the AHEAD model. And unsurprisingly, we have several concerns about this proposal. So Blue Cross and Blue Shield of Vermont has participated in the all-payer model every year from its inception until 2023, when we withdrew due to the lack of tangible quality outcomes, inability to bend the cost curve, and the new data approach that introduced concerns about security and privacy. We withdrew because we could no longer say that this experiment was in the best interest of our members. This provision would prevent us from being able to do that. The AHEAD model, and especially global hospital budgets, if designed well, may contain cost growth in Vermont. There is a lot of promise and a lot of risk. The details are extraordinarily important, and it's designed to just continue our current cost trends into the ongoing trajectory and allow through exceptions on drug income, for example, which is a major cost driver for Vermont premiums. There are other ways the global hospital budgets could not work very well. And then costs would continue to compound at an unsustainable pace. So the way this bill is drafted, the Green Mountain Care Board would have to approve growth rates determined through the global hospital budget process and no longer have independent decision-making authority over that part of the process. We think this is a little bit bizarre. It undermines the regulatory process and takes the teeth out of the regulator charged to contain system costs. So I, looked through the NOFO, and I would note that it does say that states will be expected to leverage available legislative or regulatory authority to hold commercial payers accountable for total cost of care growth. We understand that. We're not sure that mandating that we participate in global hospital budgets in the way that this does achieves that.
Can I ask a question there?
Yeah.
Because currently, some of that work is done between two different regulatory agencies, DFR and Green Mountain Care Board. How do you see the Green Mountain Care Board facilitating that kind of decision-making that you're talking about?
I'm not following you. I'm sorry.
With the AHEAD model.
The AHEAD model,
Yeah,
yes.
that we must hold private insurers accountable.
Mhm.
Where would that accountability happen from your perspective?
So the Green Mountain Care Board has a lot of regulatory authority over commercial insurers. They're approving our rates. There's a lot of policy decisions in those rate approvals that require us to do different pieces of it.
And in terms of quality metric analysis and so on. So, okay, so you're interested in having the Green Mountain Care Board continue that work or actually expand? It would have to expand some of what it does.
It would have
Within
to.
the, okay, so you're recommending that. I want to make sure you're recommending that.
Yeah.
But we don't have language now within the potential AHEAD model. We don't have any legislative language, or we haven't had a recommendation that says if the AHEAD model goes forward, then.
I would have to
Yeah,
look
we'll
through the
have to
Green
look at
Mountain
that.
Care Board's authority, but they have very, very broad
No,
authority
I
already.
understand that, but with specificity with respect to what is happening in AHEAD, I guess is what I'm thinking about, because it's got a lot, expansion of our value-based payments and so on.
Yes. So the other thing that this section doesn't do is it says DFR would mandate the commercial health insurer to participate. It doesn't give DFR leeway to make any decision based on their expertise. So for example, DFR oversees the financial solvency of Blue Cross and Blue Shield of Vermont. They would not be able to make a decision based on our solvency. Same with the stability of the health insurance marketplace. They wouldn't be able to look at what's happening in the marketplace and say, hey, maybe this wouldn't be the right move for Vermont at this time. An example to that would be, say, the global hospital budget model increases premiums substantially for our members. We could have huge employers move to other commercial health insurers that wouldn't be required to participate. We'd lose a huge percentage of our business, and it would jeopardize, I believe, the marketplace. So if you're going to move ahead with this, at the very least, you have to give DFR their, right to decision-making process based on, criteria. And then I guess I would just finish by, is mandating participation going to result in a functional system? If the largest health insurer in the state must participate in any event, do we have any leverage to advocate for the interests of our members and customers? Will our questions and concerns be given adequate consideration? How about designing a system that works and provides benefits for all Vermonters so that we all want to participate? We must learn from the past mistakes from the first all-payer model and ensure there's room to protect Vermonters when the reform experiment leads to unbearable costs without corresponding improvements in the quality of care. I would also say that the AHEAD model does require hospital participation. That's not mandated in your bill. So it's only
We can
working
fix
on one
that.
side of the aisle
We
and not
can
on the
fix
other.
that.
Yeah, and then you don't want to get into all the details. Does
Yeah.
the insurer have to participate with every hospital? Some of the hospitals, there's a lot of questions here that I don't think you can adequately legislate. You need to leave some more room. I think I'll just briefly mention sections 3 through 7. This is where you're shifting the responsibilities between the Green Mountain Care Board and AHS. The language that we object to most strongly is the language that only allows the Green Mountain Care Board to engage in payment and delivery system reform to the extent so directed by the General Assembly, which always happens, or in collaboration with the Agency of Human Services. And that sentence appears at least 3 times and perhaps more in there. Section 8, allowing the Green Mountain Care Board oversight of Medicare-only ACOs, we support that. Section 9, the Green Mountain Care Board mediation of contracts between providers and payers. We have a lot of similar concerns to the Vermont Medical Society. I think we all know why this section was included. I think you're setting them up for an impossible task. And I'm not sure what the Green Mountain Care Board brings to the table, and if the time and resources that it will take to mediate will result in tangible outcomes that are worth the effort. We already notify the Department of Financial Regulation, who has contract authority over health insurance, in advance of a termination that's going to impact our members. If you choose to move forward with this, you definitely have to include a threshold. We terminate contracts all the time, all across the system, for a whole host of reasons. And so I think you could swamp the Green Mountain Care Board pretty quickly with mediation requests. So that's that. Credentialing and quality measures. We understand the goal to streamline credentialing and quality. I think we support the goals of that. We would say that Blue Cross and Blue Shield of Vermont must be NCQA certified. It's a national certification. It requires that we credential. We cannot have a rubber stamp credentialing process in order to be NCQA certified. Without that certification, we can't sell insurance on the Vermont Exchange. So we can't give up our ability to credential providers. The other thing that we've noticed is that not all providers right now who are eligible to participate with Medicare have enrolled with CMS. It's a trend we're noticing, that there's fewer and fewer, and especially in the mental health space, providers choosing to enroll. And the other thing I would say is that they also have to accept our terms and conditions of agreement, so it doesn't automatically enroll them. The last thing I would say is that there are a lot of providers that Blue Cross and Blue Shield of Vermont credentials and enrolls that Medicare does not. And I have just a quick list just to give you an idea. So naturopaths, licensed alcohol and drug counselors, psychologists, board certified behavioral analysts, certified midwives, acupuncturists, athletic trainers, hearing instrument specialists or hearing aid dispensers, licensed genetic counselors, international board certified lactation consultants, licensed professional counselors, and pharmacists performing medication management outside of the retail pharmacy setting. So there's doulas. I think I would have to check on doulas. So there's a lot of things that would need to be worked through. This isn't sort of a simple change. And then on the CMS quality measures, they're focused on people over age 65. So we believe there's a lot of important quality measures for the population that CMS does not require. And just to get a few examples, child and adolescent WellCare visits would be excluded. Childhood immunization status, as well as adolescent immunization status, any measures for adults less than 65 years of age, and any measures that we have around engagement for prenatal and postnatal care. So you would be excluding all those kind of measures by narrowing it down just to CMS measures. I'm going to move along quickly. The decorum training. I will just say that Blue Cross and Blue Shield of Vermont, and I personally have attended thousands of hours of Green Mountain Care Board budget hearings. And I believe that they act in a professional manner and ask tough questions, and that this is unnecessary. On population-based hospital budgeting, maybe I could benefit from more explanation about why this is prescriptive in the bill, that it's a per patient based budgeting, because my understanding is that the consultants are still developing our global hospital budget methodology. It sounds crazy, but I actually keep thinking of education funding when this comes up, because in many ways it aligns. And if you base it on population, we're gonna face a lot of the same issues that we worked through in education funding with this hospital program. So if you base it on population, all our population is in Chittenden County, you're gonna starve the rest of the state unless you adjust. And I'm thinking about small schools grants, which we had way back in the day. Some of the same issues around capital.
We have a wait for that now.
Okay, yeah, and there's a lot. I mean, there's ways to solve these problems, but there's a lot of parallels in what's being worked through here. And I wouldn't want to prescribe it in statute before we work through the methodologies. So I think that would be the high level summary of our concerns with this. Section 16 about regulatory alignment. This has been worked on multiple times. We absolutely support regulatory alignment. I'm not sure another study is going to get us there. And on section 17, where you have the Attorney General's office review mergers, affiliations, and divestments, we actually continue to be very concerned about private equity in healthcare. And we would really
that underlies some of that language.
Okay,
Yeah.
I have language in another bill that would
okay.
require some reporting. It's just transparency.
Okay.
That's all it is. It would require each of the entities in healthcare that is already regulated, so health insurers included, hospitals, it excludes some groups, to report to our regulators if there's private equity investments in our organizations.
Can you is that language around somewhere?
Yeah, it is around.
That would be
Happy to
great.
send you that.
I don't know who drafted it.
Yeah. I'm sure Jen did, because she.
Jen must have, but we'll pull it out of her.
I'm gonna skip 18 for 1 second and come back to it, and just note that the effective dates in this, having everything done in this July, is super ambitious. So I don't think it's possible. We have been discussing the VCure's Vital Data Combination Project, which is, a study here for quite some time. And Blue Cross and Blue Shield of Vermont has a lot of concerns about that proposal. We don't support it because combining the health insurance database and the clinical information creates a lot of data privacy and security issues, as well as considerable legal, financial, and practical considerations that I have some more information on. Of further concern, we don't believe it's clearly articulated what the potential uses are of this data. It's really research. It can't be used for clinical improvement, which we all want, because the health insurance data is so late. It's at least 6 to 9 months lag, so it's not helpful for that. It's also very incomplete because the self-funded marketplace is not included, and more companies are refusing to share their data. So we think that the cost for this type of project and the resources that we would have to invest in this state, and let's face it, there aren't that many data people amongst all the different organizations working on the data. At Blue Cross, at the hospitals, at the Green Mountain Care Board, we have finite resources. Do we want to invest them all in this one project with a very uncertain benefit to Vermonters and a substantial cost? So I could get into a lot of the details, and maybe you should hear more about what this involves, but there's a lot of legal and governance issues around it, and I appreciate the idea of putting it all in one place and at least working through those issues in a single forum. But right now, some of the data is governed by different rules. For example, the Medicare data is limited in how it can be shared. Our understanding is that Medicare data cannot be combined with health data at all, so that would be excluded from the database. I talked about the resources. I mean, I can send you the notes because there's a lot here. Our other issue is privacy. So a massive database of personally identifiable information, no matter how incomplete, has enormous value to unlawful actors. The cybersecurity company Critical Insight released an analysis in February 23 that nearly 50 million patients in the United States were affected by data breaches of their health records in 2022. And just the first 6 months of 23, I don't have updated data right now. The number of patient records exposed so far has reached 40 million. We have considerable concerns just about the safety of this information. If it's not going to be that valuable to the researchers, and certainly not valuable on the clinical record, why would we put it all together and make it available for cybersecurity risks? So I think I'll stop there because I know you've got plenty of
No,
other
that's
people
great,
to
and
hear
if
from.
you can get
And I
into
will
written testimony,
send
I'm
it to
sure, we'll be diving into a lot of this. So appreciate your comments and your testimony when we get it, it's great.
Yeah, and one last thought on data. I was a data analyst for years. I love good data. So our opposition is not because we don't believe
No,
that
we
good
understand,
data is useful.
we understand.
Thank you.
Thank you. All right, and so Abe Berman is here. So Abe, welcome,
Thank you. Thank you for the opportunity.
and why don't you introduce yourself for the record, and do we have your testimony?
I will send it to you
And
after.
you can send it along after, as long as we know we're getting it, then we can pay full attention.
Absolutely. And I don't have any slides, so we can just
Right.
talk with each other as Vermonters. My name is Abe Berman. I'm the interim CEO of OneCare Vermont. I use the pronouns he, him. Thank you for the opportunity to offer my thoughts on S211 and to share our experience and thoughts as a regulated entity. I wanted to start just because oftentimes we can get caught in the machinations of talking about the system just to make it about the patient. It's very hard for patients to navigate the healthcare delivery system in our state and across the country. Working in healthcare, I have countless friends, family members, and loved ones contact me asking for help, how to navigate particularly the diagnostic odyssey. How do I get from I'm not feeling well or my loved one's not feeling well to a path of treatment? Just two concrete examples is a friend whose wife struggles with seizure disorder, which is separate from epilepsy that she has, as well as mental health issues, and trying to get her the right level of treatment so she can live her life and take care of their children is so complicated that relied on my having an extensive network of contracts around the country that I could get him to finally get him on path. That took 16 months. That's a mother of two children. Another example is a friend whose sister has struggled since birth with developmental disabilities. She was coming to visit from rural Massachusetts to Vermont on the bus. She unfortunately slipped getting off the bus and fractured her ankle in multiple places and has a lot of cognitive issues that make it difficult for her to exist independently anyway. She was without her husband, and he called me saying, what do I do? Where do I take my sister right now? I took her to Fanny Allen. This doesn't seem to be the right place. What should I do? And I won't go into the whole odyssey of how we got her back safe at home and on a path to care, but echoing what Dr. Fisher said, the acute care sort of myth is that we're just providing too much of it. It's really, where do we get people to get them the right care at the right cost, the right quality, and gets them back to living their life and not lying in a bed. I really truly believe that when the Vermont all-payer model was set up, it was designed to test whether we could have an impact on things like this, and whether scaling the ACO structure across all major payers in the state could incentivize delivery system transformation to reduce spending and improve population health outcomes, but most of all, to reduce complexity in the system, to help providers work together across the continuum to help patients navigate through the system. And this isn't just the average patient. We're talking about the people who, if you think about a Pareto, the 80-20, the 20 that really drive a huge amount of expense because of the level of complexity and comorbidities that they face. So beginning in 2026, CMS is no longer going to offer single state models. So I want to be really clear, that model is ending. So we need to know what we're going to do next, right? We've talked about the AHEAD model. I think the AHEAD model has many attractive attributes. One of the issues I have with it is it's a little bit of a hodgepodge. It's got a hospital global budget model with a primary care model that gives additional funding to do some additional things, but there really isn't a linking agent between the two, and it leaves out a lot of players across the continuum that can help patients to navigate through complexity. We just began an extension year, 2024, for the all-payer model. We can potentially, again, extend in 2025, but I wouldn't be doing my job if I wasn't thinking about what do I do next to continue the work that we've done and build on it iteratively, and also think about what needs to change. And when I think about change, you have to examine what is working and what isn't working. For me, you know, research has shown that public-private partnerships are foundational in successful innovation. But I also know, because my wife is a baker and a small business owner, that too many cooks in the kitchen become a real disaster, right? That's why I stay the heck out of the way when she's baking and I just do as I'm told. I think role clarity and definition, as well as aligned interests, are really important. I think effective, consistent, responsible regulation that's based on established criteria is a really essential component. And I think that the proposed legislation presents an opportunity to reflect on what's worked so far in regulation. And think about, there are things that work. And I will say, when friends ask me, well, who regulates ACOs in healthcare in other states? And I say, nothing like we have the Greenmount Care Board, for good or bad. We have a very unique setup here. And then we think about what improvements we need to make as we enter into this new phase of the transformation journey. So I was really pleased that S211 addressed issues that aren't working today, such as requiring commercial insurers to participate in reform, clarifying the role and function of the Greenmount Care Board, and establishing a multi-year focus on measuring success. One of the issues we face in healthcare is it's on a one-year cycle. We know that things don't change in 1 year. So we need to look at it over a long period of time. So I'm excited the AHEAD model looks at a longer period of time, but I hope that we don't change what we're looking at over that time. We have to be dynamic. The environment changes. I don't think anybody predicted what would have happened in 2020 and that would change our focus a little bit. However, you need to have some level of longitudinal stability in the way you evaluate success, or else you get the problem we're in today. And I can tell you, having been in this role for 8 months, the major problem that these ACOs face is being tasked with everything, similar to our compatriots at the Greenmount Care Board, too broad. And just when we think we've made some progress in one area, it's like, well, what about this? When everything's a priority, nothing's a priority. We know that. So how do we get there? You know, for me, unfortunately, my experience as a regulated entity so far is that the regulation has not been consistent or stable. So role clarity, predictability, and stakeholder input are really important. And I know the word predictability came up in Devin's testimony last Friday. What I mean by predictability is that we understand how the regulators are structuring their evaluation, and we can work with them on common goals of how to achieve that in our budget and construction. If when we construct the budget and we construct our priorities in May and we come back in December and those priorities have changed, it's very challenging to be proactive and try to develop a pathway forward. And that's what I've experienced so far. I'd also say that unpredictable and significant mid-cycle changes in having a 5-person board with 5 different personalities and 5 different sets of priorities is a real challenge for the healthcare system. I'd like to see the board come together and really crystallize what their vision is and what they want to do in a real way. And I loved what I saw in S211 that brings together other elements and solves the too many cooks in the kitchen problem, where we can agree on what is it we're trying to do and work together to get there. We're a very small state. Everybody in this room works in different aspects of healthcare, but we need to work together and not in opposition to one another. That's difficult. There's always a lot of power struggle. There's an element of control. There's an element of secrecy. And you know, I know one of the reasons why Blue Cross struggled to stay in the all-payer model was about identity, control, and competition. I get that. I worked for an insurer for 4.5 years. I watched the insurer I worked for walk away from a very, very large contract with the state of Connecticut because they did not want to disclose anything about what the proprietary rates were for different providers in that state. And getting back to what you talk about having equitable rates across the state, they viewed that as too competitively sensitive to engage in and walked away from the contract. I understand. So as I said, I think, unfortunately, trust has been eroded a little bit, and I disagree with Elliot to a degree that everybody hates the ACO in Vermont. I think 9 out of 10 Vermonters have no idea what an ACO is. I talk to them a lot. It's okay. I think 1 out of 10 Vermonters doesn't like the ACO, perhaps because it's not what they want. They want a single payer model. They want a model that protects their particular interests. Or they just heard something about it that sounds bad. Don't they take my data and share it all around? I don't want that to happen. So I think it's difficult to live in a non-patient facing portion of the way we deliver healthcare. No patient knows what I do or why my team does what they do. We're sort of like the Intel Inside sticker on the computer. It makes the computer work really well, but nobody knows exactly what the heck it means. That's my burden and my cross to bear. I'm fine with that. But I think going forward, we need to build on the momentum, the progress that we've made in the last decade. I really think ACOs, whether you want to change the name or not, I'm fine with that. And I could be OneCare, TrueCare, BlueCare, I don't care.
Green care.
There are mechanisms to unite providers across the continuum of care as we move away from fee-for-service. I recognize that healthcare data is very sensitive. However, if we don't allow providers to work together and share information, how do they identify those rising risk patients? How can they help them navigate the system? Focusing on rising risk is the way we move to being proactive and get out of sick care into healthcare. Because we can't make that jump when somebody shows up at the emergency room. We have to get to them before they show up at the emergency room. So I have concerns about the AHEAD model only because to help hospitals live within that budget, the whole system will need to work together and share aligned incentives around keeping people out of the acute care environment and also providing throughput, whether it's into a facility that we build or whether it's getting them back to their home. It's really important. I watched my mother suffer a broken hip at age 77 and think her life was over. And we were very fortunate to be able to take 8 weeks, my sister and I, to work with her and get her back through surgery and rehabilitation to doing the things she wants to do and living the life she wants to live. I'm happy. She just recently finished a trip to Florida and she's headed off on another trip soon to visit her relatives in California independently and feeling like she can do anything she needs to do. That's what we want people to experience in retirement. So, I think OneCare has done a lot for the Vermont provider community. I'm not to say that we've been perfect and that we don't have a ton more work to do, but we've allowed that data sharing to happen. We've created a legal safe harbor for that to happen. We've also relieved providers of some level of administrative burden. I don't know if everybody in the committee is familiar with MACRA and MIPS, but there's a lot of quality reporting that will have to happen if the ACO doesn't do it on their behalf. It will also subject them to losing payments from CMS, which is important. Again, we're a small state. We have the second or the lowest cost per beneficiary for Medicare beneficiaries in the country. What that means is we put extra strain on our commercial insurers because we need to still field a full-fledged healthcare delivery system in a rural state. I think we need to think hard and long about how we can not lose what we've gained there. And I'm disappointed that there isn't a model that can bring forward the all-payer model and allow it to continue. However, CMS does have a program that graduated out of CMMI and moved to CMS called the Medicare Shared Savings Program. I know about this because I actually helped OneCare into it a decade ago. Many health systems and providers are in the MSSP around the country. It is wildly successful. We can enter into that, and it can work in lockstep with AHEAD if the state chooses to move forward with AHEAD and allows us, again, to continue providers being able to work together, share information, and also have skin in the game so that you have aligned interests around wanting to keep people out of the acute care environment. I don't want to take too much time, but I think an entity that helps drive decision-making the right way, provides progress on alignment around social determinants of health screening, which is what we're doing right now, allows access to waivers to actually change some of the things that don't work and all these complex aspects of the way our healthcare system's set up. things like getting transportation from the emergency room to the Brattleboro retreat when there's a bed open, but there's no way to pay for somebody to get there. We do that. Provides the comprehensive payment reform model that really allows primary care practices to do their best work, gives them the resources. So it's not just all on the provider's back. They actually have the right amount of support that they can't work from their daily basis. And again, allows us to stay eligible as an advanced alternative payment model, which unfortunately AHEAD as it stands is not. AHEAD's sort of a reversion back to fee for service and is not considered an advanced alternative payment model. So you lose that exemption from NACA requirements. So I'm going to continue our work as an ACO this year. I'm going to keep looking at what the future might hold for the ACO, whether we call it an ACO or not. I want a way that providers can work together and collaborate. I want to keep that as low cost and lean as possible. But in order to do that, I really, really appreciate that you're looking at what the Green Mountain Care Board's tasked with. I think it's too big, and I think there's too many cooks in the kitchen. So I'll just leave you with that and say I appreciate the opportunity to speak here. I know that your work is very complicated, so thank you.
Well, thank you very much, and please do get us your testimony so we can post it. That's great. Thanks. And I'm not seeing questions around the table. Okay.
Oh, I moved out too quickly.
You did. You were leaving town quickly. And so we do have, is Dr. Laurent is here? Is Dr. Laurent here? Who's here from the Board of Nursing?
I'm Lauren Lehman. I have been given a
Oh,
promotion
Lauren.
to doctor, but I am not.
Okay, so who is, I don't know who you two folks are. Are you here with the Board of Nursing or for another, something
Yeah,
else?
I'm Kristen McClure, and Steve West, and I'm Steve Workhouse.
Okay, all right, so you're next. You're with her. Okay, great, that's good. Not yet. No, first we have, Lauren Lehman and from OPR. So, do we have your testimony yet or not?
Yes,
Yes.
ma'am. I submitted it late at like 8:30 this morning, but it has been submitted.
It's posted. It's great.
Awesome.
Thank you.
Thank you, Kiki. Thank you.
Go right ahead with your testimony and, good.
Great. Thank you so much. My name's Lauren Lehman. I'm General Counsel for the Office of Professional Regulation. I'm here testifying with and on behalf of OPR with Sheila Boney, who's our Executive Officer for the Board of Nursing and works with OPR, and Jennifer Laurent, who's the Chair of the Board of Nursing. I think she might have to step away in a moment, but they're here if we have any questions about nursing education. We're here specifically today to testify about Section 13 of S211, which instructs the Board of Nursing to create a student nurse apprenticeship program. We'd really like if the board or if the committee could consider shifting that provision into a report rather than an instruction to establish rulemaking. The reasons for this is, OPR works very closely and the board works really closely with stakeholders throughout the nursing community in Vermont and the healthcare community to develop pathways to licensure and education. We've recently adopted the Nurse Licensure Compact. We've recently adopted new rules with several new pathways to licensure. And we also have provisional licensure to get folks into the workforce quickly. So we work collaboratively regularly to improve workforce access for nurses. There could be some unintended consequences of adopting apprenticeship model toward licensure and practice. That historically apprenticeship was the model for nurse education, and there was consequences for for patient protection and for those nursing students coming up. And so historically, the model shifted toward a more academic and scientific based model. Before we revert or go back to an apprenticeship model, OPR would really like to engage with all of our community stakeholders again to ensure that any apprenticeship model works within our system of education, of patient protection, and of education for students, nursing students. So that is our request that we've proposed, included some proposed language for a report for section 13 in that testimony today. So if folks have any questions or want to review something, that's available as well.
Thank you very much. I think that's very clear, and thank you for meeting the other day to help me understand the issues around this, so appreciate it. Questions from the committee? Okay, thank you, and we have your proposal online, so we'll be able to pick it up as we go forward.
Thank you, Senator.
All right, thank you.
Thank you.
We're going to move on. So Kristen McClure is here, but I'm going to move to Michael Fisher, who's on the agenda next. But I wanted to ask before we do that, do you have time constraints this morning?
No, I think we're good.
You're good. Okay, great. So Mike Fisher, about 10 minutes will be good.
I think I can be brief,
All right.
simple little bit.
All right.
Good morning still, Mike Fisher, Healthcare Advocates. And I think I have this sort of interesting role of playing sweep on this conversation, at least this stage of the conversation. And I very intentionally did not develop written testimony in advance. I will collect my thoughts and provide them in writing to the committee.
Okay.
But I thought my role was to be a bit more responsive to the discussion that was happening. I also want to recognize I'm going to wear two different hats for a moment here. I can't help but recognize the hat as former state representative Mike Fisher, which is a different hat than healthcare advocate, the paid part of my hat. And so there is a narrative that is being told that I do want to respond to. And that narrative goes something like, the Green Mountain Care Board was created to do single payer. And we didn't do single payer, and therefore the Green Mountain Care Board wasn't designed right to do the task in front of us. I sat in an interesting place when we created the Green Mountain Care Board. I was vice chair of the House Healthcare Committee in 2011 when we passed Act 48. I was chair of the committee in 2012 when we did Act 171, which honestly is the place where we really spelled it out. And served on the conference committees on both of them. And in 2012 spent, I don't know, something like 5 hours being grilled on the House floor about what we were doing and what we were trying to do. And a key theme in committee and on the floor was, so let's remember the two bills did three major things. They sought to pursue public financing for healthcare. They set up compliance with the Affordable Care Act. It created the exchange, and they created the Green Mountain Care Board. And so the question came up again and again and again: do these three sections stand independent of each other? Are they too dependent on anything else? What happens if we don't do single payer healthcare? Does the rest of the bill stand? And we asked ourselves that question again and again and again, because it was, well, for two reasons. One of them is because we knew that even if we were successful in government finance, taxpayer financing healthcare, it was a number of years out. And so we needed to create something that was going to be good in the interim. And let's be honest, we knew this was a tough task that had high potential for not coming through. And so we asked ourselves in committee over and over again. I got grilled on the floor for probably 5 hours on exactly this topic. If the governor never produces the financing plan, remember the financing plan? If the governor never produces the financing plan, if the legislature never passes it, what happens to the rest of the bill? And so I want to recognize we didn't get everything right. Of course, that's why the legislature comes back every year. It's always good to look at the statute and make sure, address it for current needs. But I want to push back really strong on the concept, maybe it's a little bit of pride of ownership of it, that we weren't thinking about exactly this. And maybe I'll just also remember at that time what was going on, and this is from my memory, but before this setup, and I'll very intentionally use a Democratic administration as an example of this, but this has nothing to do with what party it is, but when Commissioner of DFR of Fishka, Steve Kimball, came out and said, Blue Cross, you get 3.5% rate increase this year, we all kind of turned to each other and said, how did this happen? What was the data? I'll be blunt. Was that written on a napkin in the governor's office? We didn't know. And so our motivation, and let's recognize this is sort of piggybacking on something that Elliot Fisher said earlier, who has access to the decision makers is important. We know that Don George gets access to the governor's office. We know that Sonny Eapen now has access to the governor's office. I don't have access to the governor's office as a healthcare advocate. The regular person doesn't. And so when you move decision-making to a person who serves at the pleasure of the governor, you have a different process by definition. And I'm not talking about and I want to echo something that Chair Foster said to you earlier. We're not talking about any individual here. We're talking about structure of government and how it works best. So, okay, let me shift. You've given the healthcare advocate an interesting role in this puzzle. Like Blue Cross, I think maybe there is a Green Mountain Care Board meeting, maybe two since its creation, that the Healthcare Advocate's Office hasn't staffed. We're there every day, and we're watching and we're commenting, and we have the sort of ominous task of representing Vermonters in this process. And so, and I think maybe we're the one entity that does this task who doesn't have a personal stake in it, who's not a regulated entity. On a high level, I will repeat, many people have gone before me who have said things that I absolutely agree with. I'm not going to get them all, but I want to repeat a basic thing that on the whole, I think the words on the page of this bill do more harm than good. And I want to be careful. I want to recognize, I understand how this bill came together. I want to say it out loud. I understand that when I look past the sponsors of the bill, I understand that it came from entities, maybe entities in this room, and so that leads to it having a bit of a hodgepodge feeling and pushing in different directions. But I still want to respond to the words on the page. On the whole, I think that the bill does more harm than good. I'm gonna use I want to use the concept of cooks in the kitchen for a minute, because I thought that was, I think I have a different perspective on the impact of this bill. I think this bill does inject more cooks in the kitchen, or more people telling people how to cook in the kitchen. I think it leads to a situation where the cook is going to have to get permission to scramble the eggs. And I think,
Not in my house.
and I think, well, I'm in an effective kitchen. And I think even worse than that, I think the cook is not even going to get to count the eggs, the data. I think the impact of this bill is to confuse the process and inject people who are served at the pleasure of the government in a way that I think will, in a large way, damage what we have. And I think, I respect and understand the need for predictability. I think that this bill has the potential of leading to less predictability. Again, because of the political impact. I want to recognize the time, recognize the task in front of you. I could go through individual sections of the bill that I agree with and I disagree with, but I want to part with, so instead, I just want to part with one question for you. How do we go forward on this bill? legislative committee time is a precious resource. Everybody wants you to spend time on particular things. And so I want to recognize that the task of even coming to agreement on section 18, the data section of this bill, will take you hours and hours and hours that you don't have, let alone 5 other sections of the bill. And so I think you have a decision to make about that. I think if you do, I mean, I think there has been this request that some of us go outside the room and hash it out. And I think we should always be happy to talk. We are always happy to talk. But a warning about that, when you send a regulator and regulated entities out to talk, there's a risk. Especially, we will not find consensus, and nor should we find consensus necessarily. So, with that, I just wanted to say out loud that risk, and recognize that there's probably 10 other things I want to say, but I'm going to let you.
So, no, but, do send us your testimony, and if they're section by section, if you have specific comments that will help the bill go forward, that would be extremely helpful. And obviously, we are not going to be spending 1,000 hours on this bill in here, but we will be taking some of the things that we've heard that will take us forward and that we can do. And this is going to be my comment at the end of the day, but I'll say it now and I'll say it again. So I appreciate your comments.
All right.
And our good work back in 2011. I'm using our because we were both doing the same thing. So,
2011 and 2012?
Yeah. Thank you. Questions for Mike?
Just one question. So, there are a lot of advocates in the room. There's a lot of people, there's a lot of stakeholders in the room, outside the room. Committee time is very limited. The hours in a day are very limited. I recommend, and I've never spoken to the chairman about this, but I highly recommend the format which Dr. Fisher used, which is kind of stoplight. Go, no go, and why. Very helpful. Otherwise, it's a lot of words. And, just kind of keep us focused. So what I'd like to do is take every single advocate and line them up, take this bill and say, oh, here's a common line, or here's a majority. What are they thinking? Or not, what are they thinking? That would be very helpful. Otherwise,
We can chat about how to do that.
I agree that it's really helpful, and I myself asked for that from the Green Mountain Care Board, and I'm happy that Dr. Fisher and others have done that as well. I do want to say that not all advocates are the same, and we need to also be careful about equating the opinions. So there's some that, we would want to weight more heavily, and I think it's really important to understand the dynamics between the regulated and the regulators and what our policy goals are. Look at those, but I agree that quick and to the point is what we need right now, so we don't waste our time. And I also want to be conscious of everybody else's time. I know that many people in this room and who are listening spent hours and hours this weekend dealing with this bill. And that's not fair to their time either, when we're gonna hopefully scrap most of it.
Okay, thank you.
Thank you.
And I'll include in that group myself over the weekend. So I'm going to suggest that we move on to Kristen McClure, Health Data Officer, Department of Vermont Health Access. And we always learn about new folks and new work, and so we're pleased that you're here. What we'll do is have you okay, so, and we do have this online as well, so thank you for bringing it along. So we welcome you. I don't think you know members of the committee, so we'll go around and introduce ourselves for you, and then we'll have you introduce yourselves as you give your testimony. So Senator Hardy, you can begin.
I'm Senator Ruth Hardy from the Addison District. Nice to meet you.
Senator Terry Williams from Barlow District.
Dave Wiggs, Rutland District.
Ginny Lyons, Chittenden Southeast, and Senator Gulick, Martine Gulick, LaRock Gulick will as Chittenden North Central. Thank you. I always forget.
Thank
We
you.
all have new districts.
And I'm Krista McClure, I'm with the Agency of Human Services as the Health Data Officer, and I also serve as the Chair for the HIV Steering Committee. Thank you so much for having us today. We're really grateful and excited for this opportunity.
I'm Bethany Anderson. I am the CEO at Vital, the Health Information Exchange.
Thank you for being here. Yeah.
Thank you.
And I think what would be helpful, unless you're doing it in your PowerPoint, is just a quick comment about, oh, you just lost your, there it is. A quick comment about what Vital is and then what your data work is.
Sure. And we do plan on covering that. if
Yeah.
that's okay.
You do cover it, so we're good, yeah.
So we'll plan on sharing with you today the work that has been going on around health data in Vermont, as well as the strategy and vision of where we are headed, and also talk about how it interacts with S211, specifically Section 18.
Terrific.
So if we go to slide 3, some of you may be familiar with the HIE, the Health Information Exchange. And if you are, you're probably also familiar that in Vermont, we have an advanced HIE. And CMS last year commented twice that we are one of the best HIEs in the country. And really to reflect this advanced nature of the HIE, since it has advanced past Ascend receive of clinical data, we are adopting new terms such as the Unified Health Data Space to really explain that broader and more comprehensive view of the data work around that. And as you'll see as we go on, the HIE is really core to the data strategy. And Vital, as the HIE legislatively designated operator, continues and will continue to operate that. So the goals for the Unified Health Data Space, as well as the HIE, are consistent from year to year that you're probably familiar with. Is to create one record for every person, better health outcomes, improved healthcare operations, and use data to enable investment and policy decisions. So if we go to the next slide, slide 4, this comprehensive data environment, Unified Health Data Space, is envisioned to contain clinical, claims, and social determinants of health data, really unifying it and creating that one health record that we talked about as a goal. This brings together the data and leverages the technology and the investments that have already been made, which is really important from a cost perspective. We all have limited resources, both time and money, so really efficient use of those investments in technology. And once the data is together, it has the ability, with strong data security and privacy policies and protocols, to really share it across the different stakeholders, which are patients, providers, payers, public health, policymakers, and the regulator.
We gotta figure out a P for that one.
I know. The 5 Ps plus the 1 R.
Regulator.
So if we go to page 5, to really talk about the importance of this, of bringing the data together and unifying it, we're really outcomes driven. Outcomes are really important and we're focused on that. So I'm going to share with you a little story of some of the work from Act 167, which you may recall involved the Cures integration with the HIE. So we had a broad stakeholder group, and I have to credit one of the members of the stakeholder posed the question of, well, who is doing this really well? Who is bringing clinical and claims data together really effectively, and what outcome are they getting? And that was a really important question we felt we needed to answer. So we worked across our federal partners and states, and our neighbor in New York, the Western New York HIE,
is currently doing this really effectively, bringing clinical data and claims data together at the point of care for providers and providing providers the opportunity for population health analysis. They have shared with us outcomes, and it's well documented, and did studies and research on it. There are 4 specific outcomes they noticed, all of which had double-digit impact. So they noticed a double-digit impact on the reduction in admission rate, a double-digit impact in outpatient surgeries, a double-digit impact in hospital stay duration, and a reduction in readmission rate of 30 days after discharge, again, double-digit reduction. So certainly not only with the data, they said the key differentiating factor that they attribute that to is both having the data together and that population health analytics, but also the transformation within the workflow as a provider to use that as part of their standard practice. So I share that because I think that's really important as we think about what outcomes we want and how do we deliver those outcomes to Vermonters. So as I said, Vital is our operator of the HIE, which is core to the data strategy. So I'm going to hand it over to Beth to talk a little bit about Vital.
So I think you all have heard about Vital before, but really at its core, what we do is we collect and standardize and match healthcare data that we collect from healthcare organizations that serve Vermonters. We take that data into a standardized infrastructure that then allows us to have one really comprehensive healthcare record for every Vermonter. So they have a more complete picture of patient care. And what we do is we serve as a hub for both storing and then sharing that data for appropriate uses. So a lot of the areas where that data is used, and Kristen touched on some of this, I don't have as many P's, I'm sorry, but it's patient care, care coordination and care management, public health purposes, population health, and care and quality improvement. At the foundation of our work, really, everything that we do at Vital is really ensuring the privacy and security of that data. That is not just making sure the data is secure, but also making sure that we are honoring patients' preferences on how their data is shared, but also making sure that data is available for the appropriate and authorized users, because it is important data for all of the purposes that we're talking about. We are stewards of data for virtually every Vermonter, and we take that very seriously. So as I mentioned, the core is that patient consent. We, as you all know, in March 2020, shifted to an opt-out policy for consent, and currently we have about 1.1% of Vermonters who have decided to not have their healthcare data shared, and we honor that very carefully in all of our work.
That was so bad.
Yes. We also, and one of the requirements of making that shift was making sure that we do a good job of educating Vermonters about how their data is shared and that they have choices. We didn't just move to an opt-out and hope that they figured it out. We very actively do public education. You may have heard our campaign in the fall. It was across a lot, and it was hard to miss, a lot of media channels. We have staff who's not prepared to answer questions that come to us. We keep websites. We really take that part very seriously. We also have a very robust privacy and security infrastructure, and that's staffing and technology to protect the data and ensure that it is kept secure and also really available for the points where it's needed. And that those policies and that infrastructure is really guided by a number of different pieces of our services agreements or the data use agreements. We have the organizations that submit data to the HIE, founded on HIPAA, the Health Insurance Affordability and Accountability Act, state and federal regulations, the HIE's strategic plan. Like there's a lot that goes into really guiding the use and access to that data. So on the next slide, just to give you a sense of the data that we do have in the HIE and who the partners we have are, we have over 170 organizations across the state that you either submit data to or provide data, or use data or provide data that's in the HIE. And when I say 170 organizations, that's not locations, that is actual entities with multiple locations. And that includes all of the Vermont hospitals as well as their specialty and primary care practices. It includes Dartmouth Health. It includes all of the FQHCs across the state. It includes independent practices, labs, pharmacies. We have had in the past couple of years a lot of work with EMS agencies across the state to get them access to the data, as well as payers. HIE contains a broad set of types of data as well. So there's clinical data that we get from all of these organizations that includes, information about diagnosis codes, labs, a real broad set of information. But something that I think is really great is in partnership with AHS for the past couple of years and looking forward, is we've been doing a lot of work to integrate new types of data, new types of providers into the HIE. So we have an even more complete and comprehensive picture of patients, and it includes data such as social determinants of health data, Part 2 substance use disorder data, behavioral health information. And all of this, again, is really in service of that goal of one comprehensive health record for patients to be available for all the uses.
So hearing where we are and how data is managed, we'll go to slide 8, which is a diagram. There's a lot to it. We're not going to go through all of it. But, oh, yes.
Can I ask one question?
Yeah, it's up to them. They're going to be interrupted.
Oh, go for it.
Can I interrupt you?
Yeah, you can do
The data you're talking about, is this Medicare, Medicaid related only?
No.
Or are you sourcing out like Blue Cross, private vendors?
Do you want to talk about data administration?
Yeah, so we work directly with the healthcare organizations. So we have agreements, Vital has agreements with, I'll just use examples not to call them out, with the QHCs directly, with the hospitals directly, and they submit the data for largely all of their patients. Now, there may be cases where patients have asked one of those organizations to not share their data, or certain pieces we don't get, but it is across.
So it's really every citizen?
Yeah.
Okay, thank you.
So I don't prefer to have my data released, but only 1% of Vermonters have said no. I never got asked, so I know. How did you put that out?
Beth can talk you through that process.
Okay.
So in March 2020, we did shift to an opt-out policy. That was a legislative decision. And so what that means is a patient's data that is on the HIE can be shared unless they elect to opt out, but what we opt out of sharing it. But what we, for anyone who had opted out previously, which might have happened, we honored that.
So how would they have opted out previously?
Typically at a provider's office. So when you fill out your forms at a provider's office, they would have asked you if you wanted to have your data shared with the HIE. But what happens now is we do, we do a lot of public education. So individuals can know how their data might be shared, and that happens through op-ed pieces, through media campaigns. We do radio, social media. We also, while providers are not taking individuals' elections anymore, we provide a robust set of data and materials to providers so they can have conversations with patients as well about how their data is shared and that they have options. And we have done that actually with translation, so we can reach new communities. And so we do make a pretty strong effort to try to get the information out on a regular basis, not just at one time.
I don't think you're doing a good job because I didn't know about it.
Okay.
I mean, if I fill it out, I go see my provider once a year, maybe. So is there an annual requirement or? No?
It is not, it's a one-time requirement, and we honor it going forward anytime anyone makes the decision, unless they come back and change their mind. And you can ask at any time.
Okay.
Anyone can come, ask at any time if they have opted out. You can get, you can also get an audit of anyone who has accessed your data at any point.
Okay, thank you.
And we appreciate that feedback. One of the values of the Unified Health Data Space and HIE is patients at the center of their health data, and that patients are in the driver's seat and able to make decisions on how their health data is used. So thank you for that feedback. So I'll shift to kind of the strategy and the diagram, if that's okay. It's a lot going on in the picture. Again, we're not going to talk through every component, but the way to read it is from left to right. So there are three main components. On the left, we have the inputs, which is the clinical data from all payers, the claims data, and the social determinants of health. Those are the main buckets. And in the center, that's the infrastructure. So that's the HIE that we know and love, that's operated by Vital. And there's a component called Unified Health Data Space. That is where the data is brought together and centralized, again, anticipated to be operated by Vital. On the far right, this is where we have the data access and analytics. This is where we get the value from the data for these different stakeholders, the 5P and the 1R. Again, role-based access associated with strong data security, privacy protocols. So that is all very much in place.
So to clarify, this is currently going on, or are we
Oh.
working toward
Thank you for
the
mentioning that.
unified health data?
Thank you for mentioning that.
Yeah.
Because it is also color coded. So the items in green are the items that are currently in place and exist in process right now. The lighter green is in process. The items in blue, the ones in the darker blue, are part of this year's strategic plan for us to implement this year. And then the lighter blue is more forward-looking, 2025 and beyond. So thank you for mentioning that.
Thank you. Go ahead.
So can I ask, in light of that, I'm just remembering, Blue Cross Blue Shield, Sarah's testimony. You went over when Sarah testified? Okay, and she mentioned a lot of concerns about this, what sounds like is this, and privacy concerns and data sharing and federal regulations and, I don't want to speak for you, Sarah, but just general concerns about combining clinical data with claims data. And so I guess I don't know if you have a response to those concerns or how you're addressing those types of concerns from, you know, the payer perspective, I guess, but from anybody's perspective, the integration of those two types of data.
Yeah, so security and privacy is front of mind. That's critically important. And that's the reason Vital has robust data privacy and security protocols in place, aligned with federal guidelines and national requirements. But specifically for different payers, since the work is underway, that work was already started with Medicaid. That's really the leading edge of bringing the clinical and claims together. And we certainly can share with Blue Cross Blue Shield and other payers what that looks like as we progress to develop that sense of comfort and security.
And how does one get access to the data? Like, if we wanted data, as policymakers, is one of the keys. How do we get, we ask you, or can we go in and actually use the data?
No, so there are stringent protections and policies in place, which Beth had mentioned, that's maintained at Vital with the services agreements. There's also strong governance around it, and the governance are really the instructions and the data management agreements of how the data is used. So it's, no, people can't just go in and look at the data, but based on HIPAA protections, federal law and state law, and agreement with Vital services agreement, Vital then manages the access of the healthcare organization or the policymaker making that request.
And what kind of access does Green Mountain Care Board have to this data?
So currently right now, none, because it's on the provider side. That the policymakers is in the light blue, so that's more of the forward-looking statement. So that work will be underway.
Okay.
I think there are opportunities too. I think some of what when we look forward, it's different ways of providing the data, aggregated data, de-identified data. So it's not always patients' records that all of these use cases might have access to. So again, it's going to be dependent on everything that Kristen mentioned and what the use cases are and the appropriate needs of them.
And who decides what the appropriate needs are? Do you, or just the people asking for the data?
Again, it's HIPAA, it's the federal and state policies, and it's the data use agreements we have with the providers of the data. But it's not it's not something Vital decides on a case-by-case basis. It's driven by those agreements and laws.
So the distinction you have between the light blue and the dark blue, and the dark green and the light green, can you just clarify that?
Oh, sure.
Really quick.
The dark green is in place currently. The lighter green is in process right now. So it's having development work, investments are made, work is actively underway right now. The darker blue is work scheduled for 2024, which is part of the HIE strategic plan, which is a legislative required item, the dark blue. And then the light blue is more forward-looking, plan for 2025 and beyond.
And it's in the legend that you have, but just it's helpful to have you say that, especially for folks who are on outside Zoom mode.
Yeah, we would love to be able to do it all at one time, but as Sarah noted, there are limited resources across the team, so we do need to prioritize. And that is how the HIE steering committee has prioritized that work.
Thank you.
If we go to the next slide, this is to show the overlap of S211 to that current strategy that we talked about. So the items in that dark blue box are the items associated with S211 section 18. So you can see there are a lot of common features between these two. So this is how we reflected that here.
We'll let you sort that out for us.
We'll go to the next slide. This really talks about the benefits of the approach. Really 5 key items: the data privacy and the security, the funding structure, the national landscape, leveraging existing infrastructure, and stakeholder engagement. And I'm not going to go through each one, but I do want to hit highlights of certain ones. So for the data privacy security, like we mentioned, patients, the core value is patients are at the center of their health data. So that's very important to the unified health data space in the HIE, as well as the consent process, yes?
Okay, that's, several of your bullets reference, federal involvement. Is this really a federal initiative or is this really a state initiative? Are we following the feds or what's?
Well, you have to follow compliance guidelines. So for instance, there were 2 new federal rules that were published in the last month, and we are required to follow those as well. They impact Medicare, Medicaid, and the latest one also impacts commercial payers. So yes, we do follow the federal guidelines that we are required to. Does that answer your question?
Vital started as part of the state, HIE is part of the state, and some of the work that we've done collaboratively between legislature and HIE folks. So this isn't something that's happening across the country totally. That's the question I think he's asking.
Okay, when you say funding structure predominantly federally funded, well, they've got to want something.
Let me explain that, because that is a big change probably from last time you've heard an update about the HIE or Vital. So the HIE started with the high-tech funding, the federal funding helped support that. That has come to an end. So state HIEs were presented with what is our sustainable funding outlook going forward. So Vermont's approach to address that is that our HIE became CMS certified, one of the first in the country. And the benefit of that is it's largely federally funded. So we get to enjoy a smaller state share that we have to pay and contribute to it.
So matching funds from the federal government, yeah.
Good.
So that's a really important item that is relatively new in the last year and a half. For the national landscape, like we were talking about, so the HIE in the Unified Health Data Space, as we had mentioned, adopts and follows the required national standards, which is really important for data exchange. So national standards of the mechanism of how it's exchanged, and really like that data library of what all those different data elements are associated with it. So you can easily use it and ingest that data rapidly. And that rapid exchange of data and information is really important. And as I had mentioned, those 2 new federal rules that were just published, both of them had requirements for the time frame in which data needs to be exchanged. And it was measured in hours. And this isn't 2 providers, it's patient access and payer prior authorization. So measured in hours, not days or weeks and months. So that's really important that we follow these national standards so we can enable rapid data exchange where it's required. For the leveraging existing infrastructure, this is an ever-changing landscape and environment that we all work in with health and health data. So we're able to adjust to these changing rules, regulation, federal requirements with the existing infrastructure. So able to reuse a lot of what's in place, which is very useful with limited resources. For stakeholder engagement, I'll just go to page 11. The Unified Health Data Space and the HIE has a diverse set of representation across the health system.
Next one, next slide.
No, I think that's
We've
it.
we've got the
Mhm.
steering committee. Did you?
Yes, this is
Oh,
correct,
okay,
yes.
sorry.
These are all the different organizations and entities that participate, and we routinely add new roles as needed. As mentioned, it's an ever-changing landscape.
Are we still on the inside? Are we going to the outside? We're just going to the folks who are providing data?
Oh,
Yeah.
healthcare advocate is included.
Okay.
Eric is very active.
I don't see the healthcare advocate on that as a
I
voting
think it's
member.
on the left, the third one down on the left. Eric?
Oh, I see, okay, and then
Yeah.
is Green Mountain Care Board on there?
They're on the bottom right, not voting. Mhm.
Okay.
Catherine,
And, but this data, that the location of this data isn't, your office is in AHS, correct?
Correct, it's with Vital, with the HIE. That's where it's located, housed, and operated.
Okay. I'm just concerned about the data being in an agency that is, you know, a lot of the sort of concerns that have been raised already about who controls the data,
Mhm.
who has access to the data, you know.
I think that's one of the many benefits of an independent nonprofit. As Vital as the legislative body has determined to operate that. I think that's one of the benefits.
But you just said that Vital is in AHS.
Oh, no, Vital's not. Vital's a
Vital's an
nonprofit.
independent 501c3.
Oh,
Yeah.
but I asked you that, but do you work for Vital?
I don't, I work for AHS.
Do you work?
I do.
Okay, I'm
She is
confused
Vital.
about, okay. Okay,
If this might be helpful, and I'm sorry if this isn't answering the question. This steering committee is guided by AHS, brings these groups together, not to use the data, but to set strategy and direction for the HIE and for the work that we want to do. So the roadmap for the Unified Health Data Space to kind of guide the projects and the goals, not the access to the data.
okay, okay,
Does that help?
sure. Yeah, I'm just processing.
If we go to slide 12, it's a layered engagement and governance process. So like we were just talking about, we have the steering committee comprised of multiple different members of the health system. There's a data governance council. Per statute, it's required to have an annual strategic planning session that is then submitted to the Green Mountain Care Board, also in statute for them to review and either approve, reject, or modify that strategic plan. And then, of course, one of the foundational items is transparency. So all of our information on processes, on Data Governance Council is public and posted on our website. So on page 13, this is our last item. This is how the current strategy intersects with S211. So it's fairly consistent, as we saw on that slide, showing the blue contrast in those boxes. And the key takeaways is really this box at the bottom. The key strengths of the Unified Health Data Space strategy creates a single source of trusted data, creating that one unified health record for patients. From a cost perspective, it leverages existing technology and existing investment across the spectrum. And then, of course, data privacy and security is of utmost importance, how it's stored and managed and used. And again, critically important to keep Vermonters in the driver's seat of their data.
Thank you.
This has been very good. I'm not sure that the committee has heard this much about data, clinical data and integration of clinical and claims data. And I do want to ask you a question. And that is with regard to what you said about New York earlier. And where is New York in this process? If we were to look at your slide, number 8, that has the little flow chart with the blue and the green, where does New York sit at this point? You said they were being effective in integration of data and access to data. Can you talk about that a little bit?
I can talk about what they shared with us.
Okay.
We're probing them to better understand what exactly are you doing with clinical and claims data? How are you bringing it together? How are you using it? How was the study conducted? Who participated? So regarding like social determinants of health and that component, we don't have visibility to that yet, but we have ongoing conversations with them to keep learning about what they're doing. How they're doing it right now is they're receiving clinical data for their practices that are participating in this. They have the claims data married together in dashboards for the providers, and the providers use it in 2 ways. One, for individual clinical care for a patient, as well as population health to view their full patients. They also, one of the differentiating factors that Western New York HIE is doing, which I think we could learn a lot from, is they work very closely with their providers on what do you need? What measurements are important to you? What do you want to see on your dashboard? How do you want it to fit into your workflow? And I think that we can learn a lot from that.
How are they using the clinical improvement data for, in a regulatory environment? Are they doing that?
I can follow up with them.
That would
I don't
be
have
great.
insight to that. Thank you.
And then the other question is, when you are working with them, is your governance group, your group of stakeholders, interested parties involved in those conversations? Have you invited them into that group?
Not yet. We have had the calls with a member of the Green Mountain Care Board to learn more about it, but we can certainly expand those calls to a stakeholder group.
Would be interesting to know how it flows, and then, certainly because they're asking providers directly, what do you need, and what kind of clinical improvement can we make, and what, with the dashboard, and that sounds very exciting. So, I was gonna go to cost in a minute, but.
For the record, Noel Downs with this cost. I just want to make a quick clarification to Senator Hardy's concern about Vital being, they're not just a random nonprofit, they're in statute. And I just sent you the language about all the governance and all the words and stuff about in statute.
And I'm trying to remember the year we did that, but.
Long time ago.
Can I ask another question?
Yeah, sure, go ahead.
I guess I'm just confused because, it sounds like, I'm all for unified data, like, don't get me wrong about that, but we've gotten testimony that makes it sound like this is not as far ahead as it is. You have this whole, thing, so it doesn't sound like the stakeholders are actually informed about what you're doing. Because if they were, we wouldn't have gotten testimony saying, hey, hold up, we shouldn't be doing this because this is happening. And we have a number of stakeholders who testified in opposition to what you're doing. But not just because, but in opposition to what you've already done. I can't exactly describe it, but it doesn't,
Discomfort.
This is further along than than the testimony we've gotten from other stakeholders makes it sound. So that leads me to question how much you're actually involving all those alleged stakeholders.
Absolutely involved. So let me talk to you about that process. We meet 4 times a year, quarterly. We just had our latest HIE steering committee meeting. We have an annual strategic planning session in September in person. Every stakeholder participates. They share their focus items for their organization and we prioritize together. Then we follow up the following month of this is This is the priorities that we've determined as a collective group for this year and next year. They're actively involved, have edit capability for the HIE strategic plan, which is a legislative requirement. And many do join the Green Mountain Care Board public hearing on it as well. I do want to note, in case you're wondering about the claims. So we talked claims, we didn't talk cures. So that's a differentiating item for us. So while we're saying integrate claims, the Western New York HIE has integrated claims. That is not the same as integrating all payer claims database or cures.
Okay.
If that's helpful.
Yeah, that is helpful. Okay. Still processing all of this, but.
And we're happy to share more information or come back at a future time too.
Okay, thanks.
We'll do that.
And I'm still processing how you go from individual privacy agreements between different entities to something that's so kind of global. And maybe I'll just have to sit with this for a few days and reread it, but that seems, I don't know, it just is not clear to me how that's happening.
And just, we did take testimony about this a little bit last year, but I think this is a really important question because there've been a lot of concerns about data privacy in this area. Do you want to respond?
I think it's important. There is a robust work around data governance that happens. We support all of this, and it's very specific to the types of data, right? Clinical data is going to have different rules about how it can be shared from social determinants of health and what that is defined for. And those are absolutely things that we work through, and the steering committee and subcommittees of the steering committee do work through with legal counsel and the agreements we have in place.
And again, we're certainly happy to come back. I know we've taken quite a bit of time, but to further talk through that.
Well, we may do that, and we probably should do that, but certainly the work that you're doing sounds like it's headed in a really good direction. From my perspective, and I don't know, maybe we should take a little more testimony so others can see it differently. So Senator Weeks and then Senator Williams. And then Senator Brewer.
Given that you didn't have any feedback on the language in S211, I would assume that you probably had a heavy stake in drafting the language of section 2.
No, not at all.
Okay, all right, that's fair. Good. Given that the system is being developed, it's in progress now. Do you have any benefits that you've already recognized? You know, some wins to say, hey, this is, you know, we anticipated this would be a benefit, but this is, you know, what actually happened, and it's to the benefit of Vermonters in general.
I can talk about through the COVID pandemic, so I'm not sure how much we actually shared about the HIE involvement in the COVID response, if that would be helpful.
Sure.
So during the pandemic and the COVID response, Vital and the HIE played a really key role. And I'll highlight two specific areas. One, for the hospital stay duration. That was a blind spot that the state HS, we didn't have visibility to. And right, we don't receive that clinical data, we didn't have visibility to that. That's where the HIE stepped in and provided aggregate data of the number of COVID positive patients hospitalized in the duration. And that was critically important for hospital planning. So we used that information working with the modelers from my PCHEX team to really model our hospital threshold and where we need to bring up the surge sites. And Vital was critical as that aspect. The other item I want to highlight, because it was a huge help for the Department of Health, all these tests were coming in from different labs, new different labs were being stood up to perform COVID tests. You're probably familiar with the Broad Institute. They were doing hundreds of thousands of tests. Vital was the one that created all those connections to the labs and to get that data. And then it was the big filter. They all sent it to pharmacies to Vital, and then Vital, real-time exchange, the Department of Health, where they could then use it to start contact tracing. So that reduced the time for the virus to double because people were notified so quickly with that funnel. and the real-time data exchange. Otherwise, the Department of Health would have kept receiving faxes and phone calls and had to create new connections, which take weeks and weeks and weeks with each pharmacy and lab. And we didn't talk about it very much because we were very busy working on the COVID response.
Who's next?
No, you were,
No, this is for the chair. I like
Okay, all right, go ahead.
Well, I just have, I just want to share some comments and frankly feelings, although I'm trying to remain dispassionate about S211. And I'm sharing this with my committee that this is a sweeping bill. And with every passing day, it seems to become more complicated and complex. There are 3 new senators in this committee, and I feel that we weren't prepped. We did not know this was coming, and it's feeling extremely frustrating to me to get my arms around it.
Thank you, Senator. And so one of the reasons we take testimony is to accomplish some of that. We're starting to get a picture of what needs to go and how might we put in some of the pieces that will move forward. But go ahead.
So, and I can say, going along with Senator Buick, that, you know, there's probably 2 people in here on this committee that really know anything about what's happened in the past that got us to where we are right now. So, and I've said it before, I'm not gonna vote in committee for a bill if I don't understand it.
You're right.
And I don't understand it.
So we'll move forward with the things that we do understand. I understand what you are saying and what Senator Gulick has said and other folks have indicated about some provisions of the bill. Some of them are just as concerning to me as they are to you, and we'll see what we can do. But before we get to that discussion area, Senator Weeks, you had a question?
No.
Okay, and I just want to say thank you to you both for the work that you've done, and you've helped clarify some of the data issues for us. And we'll try and get you back another time, because I think the work that you're doing is really fundamental to moving us forward in reform efforts or system improvements efforts, certainly, and making connections between patient and provider and then health outcomes, clinical health outcomes. So thank you for that work.
Thank you so much for having us today. We really
Yeah.
appreciate it. Thank you.
And cost. So, all right, so committee, this bill is a difficult bill. I'm not unapologetic for that. The work that we have in front of us, I think, is for us to look at the comments that we've received, and I am going to spend some time talking with Jen a little bit, and I've heard back from Green Mountain Care Board and others about maybe there's some changes that could be made, and we'll try to bring some legislative recommendations in so we don't have to go through every single line, because I know there's a lot that needs to be, it's in red, as Elliot Fisher shared with us. So we'll try and stick with the green as much as we can, and I know that will be different for each one of us, but we'll do what we can do. We'll try to do it quickly. I do think that there are some provisions in S151 that we should look at and go forward with. We'll put that one on the schedule. And then we're going to give ourselves a little bit of breathing room and look at some of the other bills that we have in committee and that we need to complete work on, including S109, which is the doula bill. So, no, this is not easy. It's not easy for any one of us, and I appreciate the angst that is surrounding the room. That sometimes happens, and we just want to make sure that we have a strong regulatory environment, that we have the data available to make the decisions that are needed, and that we build some alignment with administrative responsibilities that can reduce the aggravation and reduce the administration, and what going forward to improve quality for patients, access for patients, and reduce costs. I mean, we're all headed toward those goals that are so critically important. And I do say we in this because I think everyone around the room is shaking their heads about yes to that one. So